Okay, we will dive right in. So this kind of second part is going back to the universal intention screening is the other prong. So if yes, they want to get pregnant, go into preconception counseling. No, see if they're open to talking about contraceptive counseling. And again, this is by me, and then of course my mentor, Addie McClintock. I still have no disclosures. A couple different objectives for this talk. So here, our goals are to recognize the need for contraception in people who can become pregnant with autoimmune diseases. Also be able to show disease-specific rationale for contraceptive eligibility, and then demonstrate a stepwise approach to counseling patients with lupus, RA, or antiphospholipid antibody syndrome on contraceptive options. Again, to just kind of narrow our focus. So some background on this. Overall, there's a little bit more studies on this than maybe the last one, but studies show that just in general, patients with any kind of chronic medical condition are prescribed contraceptives less than the general population, like 32 versus 43%. And then that's also specific to rheumatic diseases as well. And it doesn't seem to impact on whether or not they're on a phytotoxic or a teratogenic medication either. So in one study, they actually found that greater than 70% of people who were on one of these medicines were not on a contraceptive. And I should say that was a prescribed contraceptive, and there are other methods that are not prescribed. Interestingly, again, to the point of why internists can be doing these things, they found that there was an association in prescribing with PCP or GYN visits, but not with rheumatology visits. And then kind of again to the specific population about with lupus. So of women who were diagnosed with lupus and at risk for unplanned pregnancy, they found that 59% of those did not receive any contraceptive counseling. And then of the ones that were using some kind of contraceptive method, the majority were reporting only using a barrier method, which does have a high failure rate. So what does this mean? Overall, this means that patients with rheumatologic diseases, just like with lupus, RA, and antiphospholipid antibody syndrome, are not getting appropriate or any contraceptive counseling, despite often having a higher frequency of visits and teratogenic medications. So we have another framework so that you all can do this as well if you run into it. And here, this is really adapted from the American College of Rheumatology, their 2020 guidelines. And so again, this is coming straight from the specialists. And here, it's really a stepwise fashion for the most part of thinking about their APL status, if it's lupus or not lupus, if it's lupus, what their disease activity is doing. And then of course, there's special considerations with a little asterisk that you want to take into account really at any point in this process. So for this one, we're going to do cases just all together. But case number one will be that first part of the framework, which is what their APL status is. Will someone volunteer to read case one for me?
I can read it. Daphne is a 30-year-old woman here for a routine wellness visit. She does not want to become pregnant in the next year, but would like to potentially in the next 5 years. She shares that she had a miscarriage at gestational age 12 to 15 weeks a couple years ago and was found to have an antibody that explains this. On chart review, she's lupus anticoagulant positive. Her medications include just a multivitamin.
Okay, thank you. So if you want to put in the chat, what diagnosis do you think that Daphne has, if any? Okay, we've got some votes for APL, APLS. All right. So just go into the next slide, which is because I thought this was confusing about what is antiphospholipid syndrome versus what is this APL. The distinction about this syndrome is, like with other things, is really on whether or not they meet this clinical criteria. And the clinical criteria, meaning there's some event, so either a thrombotic or obstetric, so an acute clot or one of those adverse pregnancy outcomes that we talked about in the first talk, along with having one of the antibodies. For this talk, it actually just matters if their antibodies are positive or not. And we say they have antiphospholipid antibodies that are positive if it's any of the following in this set. Again, I thought this was very confusing. So they'll see three different orders, which is the anticardiolipin antibodies, the anti-beta 2 glycoprotein antibodies, and then the lupus anticoagulant test, which is what this patient has. Interestingly, lupus anticoagulant is actually known to be the most prothrombotic of this set. So next poll, which again, I think you are not able to select more than one, but that's okay. It's meant just for learning. So Daphne is positive for antiphospholipid antibody, but she also probably has the syndrome because she had the pregnancy outcomes. Which of the following contraceptive options might you offer Daphne? Oh. Yes. Yes, Roxanne. So she meets criteria for syndrome. Oh, and you can select multiple options. Amazing. The suspense is building. Okay. What do we have? Amazing. Looks like you all took some things away from Nikki's talk. We have lots of votes for the copper IUD, no hormones. Progestin IUD is next popular. Then it seems like the subdermal implant. Okay. And then if I can count, then progestin only pills. Nice. Okay. Let's talk about it. So Daphne would be eligible according to the American College of Rheumatology for the following things that are not crossed out. So the progestin IUD, the copper IUD, progestin only pills, condoms, and then fertility awareness. Of course, asterisks here, these are lower efficacy options, but are still options that patients can choose. So branch point 1 in our framework, why we care so much about if they have the antiphospholipid antibodies. If this is true, you're going to avoid all estrogens anywhere. Again, going back a slide, the combined oral contraceptives have estrogen, patch has estrogen, and then also the ring. But also any higher dose systemic progestins. Okay, so think about those things that are like Nikki were pointing out, higher dose, you're like getting a big jolt systemically, not localized. So that would be things like the implant, and then also the progesterone injections, right? So our takeaway number one from this is that if they have antiphospholipid positive antibodies, you want to think IUD, either IUD or the progestin only pill. You have some things. Yeah. This is a really great point, Jordan. So here, overall, what am I trying to say? There is sometimes there's just limited data in certain things. And I think there aren't exactly specific contraindications, like saying like this is definite. The thought, I will say, which is a really great point, is that with any of these systemic progestins, there may, like just through the pathophysiology, be some systemic conversion to estrogen. So it's really on kind of like the basic science level that we think that there's a higher thrombotic risk. But a lot of times these things are not directly studied in head-to-head things or randomized controlled trials. And then if you click on the rationale, it's just like out of a paucity of data and trying to pick the safest thing. So I think, like to Nikki's point, if if someone's, the bigger thing for them is getting pregnant, having a really careful conversation about the risks is okay. Yeah. Also, progesterone pills may have a higher peak, but then drops down each day versus right. Yeah. So it not that like same like higher ongoing dose rather than just like a little jolt here and there. Case number 2, the next point in the framework is it lupus or is it not lupus? Let me see the chat. Okay. Will someone read case 2?
I can read it. Harper is a 22-year-old non-binary person, AFAB, they, them, with a history of RA, stable, well-controlled disease, who would like to discuss contraceptive options. They have heard good things about the pill, but are also interested in the shot as they heard that does not require a procedure and can suppress menses. They are open to discussing other options as well. Chart review shows history of RA, RF, and anti-CC positive, ANA and APL test negative. Medications they take are methotrexate, folate, and hydroxychloroquine.
Awesome. Thank you. So time for our next poll. So moving down in the framework, so Harper has RA, it is not lupus, and they do not have the APL antibodies. So what contraceptive options would you present as likely being safe for Harper? Ooh, all right. Okay. So looks like overall some a lot of options for a lot of people, but the lowest is combination oral contraceptives. Okay, that's 7. Oh, that's not true. I can't do math. Or maybe it's the vaginal ring. Well, either way, we will get into it.
G is the DMPA.
Thank you. So in here for Harper, the only thing that is, again, from the American College of Rheumatology that you should not be offering is DMPA or the Depo-Provera or progesterone injections. And we will get into why that is. So first things, there's kind of two learning points with this case. Branch point number 2 is if they do not have lupus, they're essentially eligible for all methods unless there's a special consideration. And there are a couple of important ones. So for them, for all these patients, you want to be thinking about osteoporosis risk. And if there is a risk for osteoporosis, then you want to avoid the Depo-Provera or DMPA injections. And this is because, so for RA itself, this is an independent risk factor for osteoporosis. So just like having that disease process increase the risk. So you would not want to offer a progesterone shot that is, I think it's like it reduces bone mineral density by 7.5% over 2 years, which is not insignificant, even if they can recover after that. And then, of course, for patients with any rheumatologic disease, you want to think about prednisone use. So it seems a little unclear on whether or not, like what dose counts as like enough to put them at risk. But the American College of Rheumatology discusses supplementation with calcium and vitamin D at any prednisone dose for greater than 3 months. And it seems like that there's an increased fracture risk for prednisone anywhere from 2.5 to 7.5 milligrams daily, again, in that time frame. So really, if they're on like any amount of prednisone for more than a couple of months, probably not the best option. So building on our takeaways. So again, if they have APL antibodies, think IUD or progesterone-only pills. For non-lupus, all methods, unless there's another factor that you're taking into consideration, which for Harper, there's this osteoporosis risk, so you wouldn't want Depo as first line. Okay. Moving on to the kind of next tier in the framework, which is, okay, let's say they have lupus. Then you want to think about disease activity. Will someone read case 3?
Sure. Lucia is a 34-year-old cis woman with a history of SLE who is here to establish care. As part of your routine history taking, you understand she has regular periods, is sexually active with one male partner, and does not want to become pregnant in the next year. Her SLE diagnosis is recent, but she tells you her symptoms are mild and she is only taking hydroxychloroquine. On chart review, she is APL negative, ANA positive, and anti-dsDNA positive. Medications are hydroxychloroquine, 400 mg daily.
Awesome, thank you. So for Lucia, same thing. So we're saying this is SLE, low disease activity, right? Symptoms are very mild, well controlled. What contraceptive options would you present? Ooh, more of a house divided. I like it. Okay. So it seems like IUDs, yeah, everyone's like 100% all the way. We were less intrigued by the implant, the combination oral contraceptives, the patch, injections, and ring. Okay. So let's see what she's eligible for. Interesting, everything but the patch. So branch point number 3, if they have lupus with low disease activity, they are eligible for all methods except the patch. That being said, the ACR does put this little caveat that they favor more effective methods and some without estrogen as well. But it's like a soft recommendation. We're going to do some myth busting again today. So it comes to you and she's like, oh, but I heard, won't taking hormones worsen my lupus or cause me a flare? I feel a little bit like a cardiologist. I'm going to give you a trial name, which is the Oxalina or OC-Selena, which essentially was a randomized study of 183 women with inactive or stable lupus. They randomized them either to combined oral contraceptives, so thinking of one of the more absorptive estrogen containing methods, or a placebo. And then I don't remember, there was something about why this was ethical about pregnancy. Can't remember. And then that study showed that there were similar rates of severe flares as well as mild to moderate flares. Overall, this found that having them on an estrogen containing method does not increase the risk of flares. And there's some postulation that it might actually help for patients if they're having more cyclical lupus activity. They had some commentary also in the study that really this messaging around hormones and estrogen specifically is based off of some mice models, and then this one like retrospective case control study as well. So takeaway here is that building on this, if it is lupus, you really want to know their disease activity, because if it's low, you don't want to withhold all these methods, and really they're eligible for all but the patch. And the rationale for the patch kind of goes back to, again, Nikki's talk. The patch does actually just seem to have more like systemic absorption rather than the like ebb and flow. Again, like kind of a softer evidence, but overall they're just like, this one seems to have more systemic absorption of the estrogen. It seems a little bit riskier. There's other options. Avoid that one. So case 3 is continued. Lucia returns the following year. You're reviewing her medications and you see that her rheumatologist has now started mycophenolate. What additional counseling would you provide her regarding her birth control? You can shout it out or put it in the chat if you think of anything. See a chat. Yeah, okay, so much more important to avoid pregnancy. Folate, always love folate. And this is something I learned thinking back to our farm days. So MMF can actually lower estrogen and progesterone levels of combined oral contraceptives, so making them less effective. So because of this, they recommend, and the fact that it's teratogenic, they're recommending the IUD alone, just as far as effectiveness, or 2 other methods of contraceptive together. So it's a REMS drug. Most of the time, the most common REMS drug people think of is Accutane or isotretinoin. So really they should be getting this through a REMS provider and have already known this information, but important for you to know, if someone is saying they're using 2 methods, they should be staying on them. And then down our framework once again, 3B, hinting with our adult wolf here. And I can go ahead and read this one. So Lucia comes back and reports that her symptoms have worsened, and she and her rheumatologist are now actively trying to get better control of her joint pain and kidney function. What options are recommended for Lucia now? And I guess, hold on, I'll pull up. I didn't actually put the things. This slide, if we can do another poll.
You got it.
But thinking this is now high disease activity. All right, the crowd is still loving IUDs. And then also for a number of votes for the subdermal implant, and then progestin only pills, and then kind of a scattering of some other ones as well. But much less common in voting. Interesting. So we're just gonna write to branch point number 4. So this image is from Reproductive Health Access Project, which is another great resource with patient-facing materials I would use if not already. But the takeaway here is, so if they have lupus with moderate to high disease activity, you want to favor more strongly progestin-only methods, systemic or local, right? So thinking of systemic being the shot or the implant, or local being like the progestin IUD. So again, they're not contraindicated for estrogen-containing methods. It's just that they favor them thinking about this risk of flares. So the takeaway here, building on, again, thinking about down the line, if it is lupus, what their disease activity, if it's moderate to high, it's really the same as above. So you're not going to do the patch. That's a hard pass for rheumatologists, but more strongly favor progestin-only methods, all things being equal. And then to give you a reference, so this is straight from the American College of Rheumatology. This is what they're seeing by their guidelines. I found this to be a little bit dense, but if you're a visual person, I think this is basically the same framework. Anything is red is what they want you, they strongly recommend against or conditionally recommend against. So the patch for lupus, and then again, these combined methods for APL. I mean, there's a lot of things in green. There's a lot of options for these patients, and they're getting poor information. At least I personally have seen many patients say that they've heard that they can't be on any hormones whatsoever. And I think it's important for us to give correct information, knowing that this is a patient population, that there is a higher prevalence of rheumatic disease in Black and brown populations, as well as a history of reproductive injustices in these same populations, and like some pretty recent pushes in the medical community saying like LARC is best. And really, like for all patients, we should be giving as much agency as possible, and doing so in an evidence-based way. So not wanting to withhold any options or give, of course, incorrect information. And then a note on the MEC SPR. So I love this. I use this all the time in clinic, but I will say for like specific disease processes, I don't actually think it's the best in this case, because the way the rheumatologists have organized it doesn't totally align with the conditions in the app. I even like walked through it on some of them. And so for some, it like seems to be more restrictive, some it seems to be less. And so I think to give patients the most options and by the specialists who they really trust, I would go off of the ECR recommendations. And then a note on emergency contraception. Again, to Nikki's point, it is for everyone. So this is in the ACR recommendations. There is no contraindication. So including antiphospholipid antibodies or syndrome, everyone can have this. As far as, and then just pulling up. So again, there's the Ella or ulipristal, which is mostly by prescription, and then Plan B, which is the one that patients think of. Would prescribe this for anyone with a method that like has the potential for user error is kind of the frame of reference. So like a barrier method, fertility awareness, or even other pills as well, because they're less effective. And then my personal practice, I'm favoring Ella or ulipristal because like what Nikki said, that it works for a longer period of time after unprotected or like a break in a condom, etc., up to 5 days, as well as for often higher weights as well. So some key takeaways, just building everything all together. Again, just going stepwise through the framework, really just thinking about, do they have these higher risk antibodies? Because that's the most restrictive step in this framework. And then if not, then looking at, do they have lupus or not? If it's not lupus, the world is their oyster, essentially, unless they have a special consideration. Then in this bucket of patients that is lupus, you want to think about their disease activity. The biggest rule of thumb is like probably not the patch for anyone. And then if their disease is higher, again, leaning more away from estrogens, thinking about risk of flare. And again, for all the reasons we talked about, pregnancy itself is a higher risk disease state. So offer everyone emergency contraceptive anywhere in this framework. And this one is shorter. That is all I have. So happy to take any questions that I will do my very best to answer, and some built-in extra time for you to take my post-test survey. Please take it.
Fantastic, Leah. Thanks so much. That was great.
Oh, and I also have a link actually to the chat, so I can, if people don't like QR codes.
You can give folks a few minutes to fill out the survey. Any questions for Leah? Post them in the chat or shout them out.
Yeah, I wonder if people are busy taking the survey, because I'm surprised. No question. I think it's kind of a controversial topic.
Awesome. I'm just seeing a lot of praise in the chat. There are no questions. Thanks so much to Leah and Nikki for great talks this morning. Well, we can end a few minutes early, let people take a little, couple extra minutes before getting off to whatever you have to do this afternoon. And we'll see you guys next week. Thanks so much.
Awesome. Thanks all.